So as I was saying, the basic understanding of pre-analytics is very important when we, as technicians and pathologists, for diagnosing. So today we're going to be talking about the pre-analytic factors, the outline of the diagnostic workflow in the laboratory, and then most importantly, the best practices around standardization and optimizing. So as we look at the what happens to a sample in surgery, we look at this as work cells, okay? So we see pre-analytics, primary staining, advanced staining, and now imaging is become so important because if we don't have good pre-analytics, this will show up in imaging, especially if we're doing quantitative reporting or algorithms. We have to have good pre-analytics right from the start. So the journey of the tissue sample, like I said, goes from a viable sample from the patient, the post-acquisition where the biomolecules may start to degrade. And it happens from the start of when the patient sample is actually taken out of the body at times, what we say is time zero. But 60 to 70% of the problems happen in these post acquisition or what we call pre-analytic areas. You will find, and I'm going to say pre-analytic, but if you are interested in ISO standards, ISO calls these pre-examination. So not to be confused if you are an ISO laboratory. So many sources of potential errors. There's a sample transport, the reception into fixation, dehydration, microtomy, slide driving, and even archiving, where we see the duration and temperature and even the types of support around the things. But all this is many opportunities for variables across the whole pre-analytic pathway. On top of that, we receive histology specimens consist of various different methods, and which could be biopsies, resections, and even tissues from autopsy, and they come from different areas. They could be from offices, from clinics, or inside the hospital surgeries. But today we're going to basically walk through the workflow of a sample. And we're going to first start with accessioning. One of the key areas that we have that problems can happen is accuracy of the sample, the actual received into the laboratory, making sure that the labels are correct and that the specimen container meets the same appropriation of the labeling of the cassette. This is one of the major, as I said, a major source of error in the histology laboratory, and you wouldn't even know that the specimen was incorrect if the label didn't match, or even the sample was put into the wrong container. So next we're going to be speaking about grossing. So when tissue must undergo a gross examination and dissection, and grossing consists of the specimen size, shape, describing the color, and any kind of abnormalities. This is then placed into a small plastic cassette, and it allows fluids to go infiltrate the specimen in the processing step in the tissue processor. However, many things happen at grossing that can actually be helped. One of them is making sure that the sections are no more than 3 millimeters thick when processing, and gross section is even thinner because of the reagents have to be able to penetrate the sample. You want to avoid any kind of specimen trauma, avoid overloading the actual cassette, and clearly have proper labels marked. Here we see on the bottom two cassettes that were, the specimens are too large within the cassette, and the one next to it, there's actually contamination in a lung sample where this foreign object was actually, foreign sample was actually was placed in the cassette and was, you see this many times on, hopefully not many times, but many times on a slide. Okay, procurement and fixation. Now, the definition of fixation is alters tissue by stabilizing the protein so it is resistant for future changes. I would like to say that it is a snapshot of the specimen at the time it was taken out of the patient. You want to be able to see exactly what was going on in the sample when it was removed and without degradation of DNA and RNA. By placing it into 10% neutral buffered formalin, it is what is used widely and most often in worldwide, and it is recommended routinely for histologic examination, mostly because many steps that happen after the H&E, such as molecular testing or immunohistochemistry testing, is all based on neutral buffered formalin and not any other sample. So that's validated against samples that were fixed in formalin. So fixation is crucial. It's a crucial step. It stabilizes the tissue and stops any kind of degradation. It helps preserve so that we can actually see the cellular architecture. It prevents breakdown of the tissue from any kind of enzymatic activities or even microorganisms. And it is a chemical process. Is gradual and is complex. And it especially for the forming those cross-linkings of protein. And I want to emphasize the fact that it is gradual. The ASCO-CAP guidelines that was presented for HER2 ER/PR testing recommends neutral buffered formalin, and the time, which we call cold ischemia, we'll talk about this in just a minute, is that placed immediately in formalin fixation within an hour from the time of removal. The minimum time of fixative should be 6 hours, but however, when they said that, they were mostly thinking about biopsies, but really optimally it's 24 to 48. And I think you're going to see some new regulations that are going to come through that are going to recommend that 48 hours be the most, although this guideline does say 72 hours. The temperature should be at room temperature and the volume should be 15 to 20 to 1 ratio of fixative to the tissue. And large samples should be opened and thinly sliced using proper grossing techniques. This study by Chung really points out the importance of, fixation and using a phosphate buffered fixative such as formalin, and also the fixation time. Here we see the dark areas is the optimal areas for RNA quality. So that being said, 12 to 24, it shows 12 to 24 hours is maximum for fixation time, that it should be using a phosphate buffered fixative, and the processing time, once again, should be within the 45 to 60 minutes per step. So just an understanding of cold ischemia time, it's the time of the removal of tissue until it's placed in fixative. This is the time to fixation. So it's warm ischemia would be from the time it's clamped off, but right now what we're talking about is cold ischemia, the time the sample, how much time does it take before it actually goes into the container of formalin? And then the time of fixation is the time the tissue, the specimen is actually immersed in fixative. And the countdown of this actually starts from the time it goes into the container, and it also includes the processing time within the automatic processor. The H&E is a key area to look for any kind of pre-analytic variables that take place. But the most important thing is to have a good H&E, and because this is the primary stain used for diagnosis process. Remember that hematoxylin is what we use, but the most important thing is the nuclei and seeing good chromatin pattern within the nuclei. And eosin should not be overwhelming, and it shows the extracellular matrix or the cytoplasm, but also shows the collagen and muscle around the actual tissue itself. When fixative is delayed, the time, again, time to fixation, we see enzymatic activity that can occur, or autolysis, and where the tissue actually starts degrading itself. On the left, you see autolysis, but on the right, you can see that the tissue is well preserved, of epithelium of the small intestine, and you can actually see the mucosa, and the epithelium has not been stripped off like you see on the left. The other thing that happens when you do not see good fixation is you see smudgy nuclei, as you see here on the left. You also see nuclear bubbling. These both are caused by poor fixation or incomplete fixation. So a lot of people think that by keeping the sample uh, wet with saline is going to help with this when we're talking about this ischemic time. However, saline actually destroys some of the nuclei, and you start seeing this kind of reaction with saline. And so it is, even though the sample is wet, you can still destroy the nuclear and RNA and DNA, even with just saline. So as an overview, let's just look at this best practice as using neutral buffered formalin that's been pH 7.2 to 7.4, making sure that the formalin penetrates fast to continue the cross-linking protein after the long penetration time is complete, which is at least 6 hours and no more than 24 to 72 hours. And this again includes the time in the processor, and making sure that you document this time. The volume should be 15 to 20 in the container, the temperature 22 to 37. And I want to also point out that there are other fixatives that we have to worry about that are not recommended for IHC, and I'll show you a sample of that in a moment. But also decalcification can cause issues with RNA and DNA, and especially when you're doing immunohistochemistry, and the recommended decalcification is EDTA. So on to tissue processing. We take for granted that once we put it into the tissue processor that we walk away and everything is a-okay and fine. However, fixation continues on the tissue processor in formalin. We dehydrate in making sure that we have good graded alcohol, and making sure we start with a low percentage like 70% and ending up with 100. The reason why we start with 70% is because remember that formalin is aqueous, and we want to take away the formic acid. Otherwise, you start seeing formic acid crystals if you go directly into a higher dilution of, or excuse me, a lower dilution of alcohol. Clearing usually is xylene, and this is the intermediary step between the alcohol and the paraffin, because paraffin is not miscible with alcohol. And so this is called clearing because you are clearing out the alcohol. And then lastly, infiltration into a paraffin wax. Here we see some samples of what happens when we either overprocess. The two blocks on the top and the right have been overprocessed, these two here, but here we actually we see water that's been put into the sample by not changing the reagents appropriately. The nuclei are usually pushed to the edge of the actual cell, and it is nearly impossible to change this reaction once it happens, other than taking another sample. So you have to use the appropriate schedule for the tissue type. So in other words, biopsies versus resections in, like, for example, brain is a very dense tissue and needs to be processed a lot longer. Make sure you document the reagent chains, and this should be done on a daily basis. Don't avoid the over processing by temperature, vacuum, and pressure. In many cases, you don't need vacuum and pressure, um, but the temperature can be ambient even, um, and it's not really needed because this reaction takes place, you know, very naturally if it's done appropriately and there is some kind of agitation, and you're not um, overstocking the cassette chamber. Making sure the paraffin doesn't exceed 60 degrees and not held for uh, extended time, and making sure you're using the right kind of wax. There are different kinds of waxes out there, and recommendation of one that is uh, plastic in there also, which makes the ease of cutting. So let's walk through some of these best practices. When you have, for example, over processed dry brittle tissue, it's probably because the temperature was too high, and or it's been excessive time in grated alcohols. Some people use Eosin in their processor so they can see the biopsies. Do not put too much in, that causes a brittle tissue. So again, we want to separate out those small biopsies from the larger ones because you want reduced times in alcohols and xylene. Making sure that you have a protocol that is correct for surgical or fatty tissue, and again, separating those. So the highlights here is making sure you avoid heat except for paraffin, and making sure you have good protocols that separate out. Clearing and infiltration. Again, over hardening can have happened in this when there's too much clearant, and overheating the paraffins can cause shrinkage and hardening. And like you see in this is a sample, the picture on the left, of dry and cracked sample simply from over hardening. So you want to make sure that you, again, have 2 to 3 changes of clearant, 15 to 60 minutes, and making sure that poor quality paraffins can actually interfere with the recovery of biomolecules, and making sure that you have good changes of the paraffins, as well as the all the samples or all the solutions on the processor. So making sure the highlights here, 2 to 3 changes of clearance, and use paraffin with melting points below 58 degrees. Embedding. You think that embedding would be simple. The technician takes it from the embedding chamber and puts it into a cassette, into a mold and then a cassette, and there wouldn't be any kind of artifact there. However, there are. You want to avoid contamination at this point, making sure you open one at a time. You make sure you clean your forceps, avoid excess heat, check and document the temperatures daily, and making sure you orient the specimen appropriately. Um, on part 2 of this lecture, that will happen between a break, we'll talk about the fact that you should not have in this chamber go from dry paraffin to and the holding tank before you embed. It should be making sure that you have your holding tank actually has paraffin in it, and melted paraffin. So orientation is just as important. You can miss a whole sample by poor orientation. And incomplete sections can give a pathologist only a portion of peak of what is actually happening on that block. So here we want to make sure that the tissue is in the middle of the center of the mold. We want to make sure that you see the full epithelium of the sample by making sure that it's placed side down, and you can tamp this tissue to make sure that it is flat on the bottom of the mold. These are tubular structures, such as you want to see a cross section here, and making sure they are on end. And once again, so you can see the full cross section. And also, one of the things that we see here is angling the tissue so that the surface area of minimizing the surface area to the knife, such as in bone, can be easier to cut. So just the highlights here, you want to embed in the center of the mold. Placement should be enabled visualization desired during that tissue structure, and place it flat on the same plane as the mold. Artifacts also can happen embedding small friable tissue that can cause artifacts. This is also what I was talking about earlier, that the hot plate surface also causes contamination, but also can cause heat artifact. So you want to make sure that the specimen is not being placed on the hot plate, that the orientation should be clean and the mold clean mold and using clean forceps. And this way you won't lose that piece of tissue. The other one that you want to make sure is, like I said before, is the chamber is dry. You never want to embed from a dry chamber. You want to make sure it's immersed and held in paraffin prior to the embedding step into hot paraffin, melted paraffin, and transfer it directly from the mold from there. And of course, be very careful when you're opening up those cassettes. I've spent many times opening up the cassette and those tiny biopsies. What you don't want is to flip it off, and it's just a nightmare if that should happen. And microtomy. So, the microtome is used to cut very thin sections from 3 to 6 microns. And this is done it's because of friction. And as you generate you turn the wheel, it generates heat, and it actually forms a ribbon by sealing the bottom of the paraffin block. So here we see some poor sample or poor technique. One is, here's an artifact that has been introduced on the slide. It could be from the water bath. It could be in the mold itself by poor embedding. So this is not good to see this kind of artifact. Here, this is a poor technique, putting two different samples on the water bath, um, where you might get cross-contamination. This wrinkling of the tissue on the water bath could be from tissue over-processed, and it's hard, and once it hits the water bath, it wrinkles. And lastly, making sure that there are no bubbles when you, like you see here on the bottom of this water bath, clearing those bubbles out, because they float up, and when they are actually stained, they burst and they cause this kind of artifact. So all these things are really important when you're doing microtomy. You never want to cut too thin, but you never want to cut too thick. The recommended solution here is routine 3 to 4 microns. IHC should be at 4 microns, bone marrows 3 microns, and renal tissue at 2. And making sure that the number of sections per slide, avoid using first and last sections of the ribbon because they can be thicker or thinner, and making sure your microtome is also serviced according to the manufacturer recommendation, and keeping up those quality documents, the preventative maintenance, to make sure it's done on a routine basis. So remember that laboratories should have standards for thickness, section thickness, so that all your sections are the same. And this is also becoming an issue with digital pathology, because if it's too thick, the imager is obviously having difficulty. So once again, we want to make sure that we have very sharp knives and we're cutting to the appropriate thickness. We want to make sure that water is not trapped between the tissue and the slide, because once again, once we put this in the actual dryer, slide dryer, it can bubble, and it can actually cause nuclear bubbling. You want to choose slides that are not hydrophobic, and you want to make sure you wick your slides. In other words, draw that water off your slide before putting it either horizontally or vertically before it goes into the staining process. So making sure proper drainage, and check for and slide for trapped water. The Venetian blind effect, which we see here, it is caused by hard or overprocessed tissue or a dull blade, and making sure there's not too much clearance angle on the microtome. So your block is loose in the chuck, or the blade is not secure. So once again, poor maintained microtome can cause this kind of artifact. So there's many remedies here, but we want to make sure that your block and your blade is securely fastened, that your good microtomy is steady motion while turning the microtomy wheel, and making sure that the presence of any kind of calcified tissue, that decal solution can be used, but making sure that it's one that contains hydrochloric acid. It does not contain hydrochloric acid, because once again, you're going to degrade the tissue. So making sure you have fresh, sharp blades, and making sure that your blade is secure. I think those are the key takeaways. Poor placement of tissue is something that we see a lot, especially in some of the EQA programs that I've been associated with. More is not good. If one tissue that's placed appropriate is better than 3 that is inappropriate. So make sure you place your tissue in the center of the slide, and that it's ease for both the pathologist, for digital imaging, and actually for the technician itself. So making sure that that is maintained, and I would suggest that you train your technicians to in your laboratories, that this is the way it should be done in your laboratory. Slide stability, people don't think about this too much, but pre-cutting slides does cause lose its anagenicity based because of oxidation. That you store the appropriate temperatures. Here's a study that was done that for published guidelines as well as literature. Storage of cut sections should be 7 days, but less than 6 weeks. The literature base actually says less than 6 days. Storage of paraffin blocks can be indefinitely, and some of the literature says less than 25 years. This usually is the mode is 20 degrees, 4 degrees C for a week, and -20 on a month, or year -80. Those are sort of the recommended temperatures that some of these guidelines have said. But also many times in package insert that's provided by the manufacturer will say what the cut stability is of slides for optimal staining. So I refer to the package insert also, because that's mandatory that you do cut stability, become a CE-IVD product. Slide drying also causes an issue. The recommendation is 60 degrees for 60 minutes, or 37 degrees for a maximum of 24 hours, or at ambient temperature for 24 hours or longer. I've done samples of this and experimented with IHC and also H&E, and really the best takeaway is ambient temperature for 24 hours. That is where you see the best nuclear detail. However, we can't do that. We don't have that luxury. So make sure 60 degrees at 60 minutes. This is appropriate. Higher, faster does not work, and you should monitor your drying temperature. This causes, this shortening of drying time actually impedes tissue adherence, and also higher temperatures causes polymerization of the paraffin and will leave residual on the slide. And many times you might see this as like a or hematoxylin ghosting around the slide, simply because it was dried too hot. The other thing I want to point out is if you microwave your tissue, I do not recommend microwaving slide drying. I really don't. If there is water left under there, I mean, microwaves only work because it needs something to heat. So it is boiling the water that's underneath the paraffin in order to melt the wax. And it's causing all kinds of artifacts, especially such as nuclear bubbling. So I do not recommend the microwave. And overall, just remember that 60 degrees, there is a range 30 to 60, but most of the regulations say no more than 60. So just one last piece of this is the last section is cover slipping. And, this is to protect the slide. Um, but once again, it's an area of issue where you can have dehydration, and mounting media can have an impact for um, the slide staining to fade. So you want to make sure when you're staining that you dehydrate appropriately and your mounting media is appropriate, because if you do not have uh, your mounting media on there correctly, if you don't have a good technique, you can cause air bubbles and even bigger air bubbles that dries the tissue, and this can cause issues for archived slides. So this once again becomes a real issue when later on when you want to pick up your slides out of the files. Not to mention, do not dilute your mounting media, because this is also caused by dilution of the mounting media. So make sure you use fresh mounting media and no dilution. Drying, if you end up drying your tissue before your slide, before it is mounted, and this can happen when you're using sometimes automated tissue, or excuse me, cover slippers. It causes a thing called corn flaking. And this is, like I said, it's drying before the mounting media is added. So you want to make sure your slides are immersed in xylene prior to cover slipping. So remember that precision medicine starts with precision pathology, and that means standardization in every step of the pre-analytics. There's multiple guidelines now that are available that you can go to for the resource. Of course, College of American Pathologists, updated some of this in regards to the HER2 guidelines around breast. There's guidelines for ISLAC, which is for lung cancer. The NSH, College of American Pathologists, put out a practical guide to specimen handling and surgical pathology that literally goes through all the steps I just talked about. Late last year, Dr. Compton presented this special article on pre-analytics and precision medicine. MM13 has been just published for the Clinical Laboratory Standards Institute, CLSI, and this walks through all the collection for even into molecular standards and molecular testing. And soon, I would probably say mid-2021, there will be an ISO standard that will come out, and that should be published for those of you that look to ISO for guidance. So at this point, I would like to end with question and answers, and I look forward to speaking to you again for part 2, which is the poor effects on poor tissue handling on testing, and what we discussed here, and what will those effects cause on IHC and molecular. So I'd like to take some questions now. I understand that I see a few already in the let me just stop sharing. Okay. And if there's any of these that are in a some of them will have to be translated, but I do have some over here that say we use Eosin and in the methanol during the tissue processing. What are the disadvantages of the use of Eosin? There aren't any disadvantages, but too much can cause an issue and can cause drying of the tissue. So I recommend just enough to color the tissue, which is just usually a couple drops in the formalin. Actually, we used to use food color dye in the formalin. That worked just as well, but also I've seen some working with alcohol. What should you rinse your blocks with after placing in decal solution? Water. That's probably the best thing, is just making sure that you rinse well with water, a water-soaked gauze or water-soaked piece of cotton, and making sure that you rinse well before you and do not take the first couple cuts. Utilize the first couple cuts after you decal, but slowly as you work into the block. I see something, some other things that are in, maybe if you want to go on the Robin, or if you can translate for me for some of the other questions.
Okay. That's I see the questions are answered. So they can answer. They can send some new questions, and later on in the second part, maybe you can answer then.
Okay, that's fine. Did I see there's something about MM13 publication?
Yeah, I mentioned it in my presentation. So there was an attendee that mentioned it that was not for free. That's correct? Eh?
No, those publications are not for free. No, they aren't. The guideline that I talked about for CAP is free. You can go on the CAP website as well as the NSH, the National Society of Histotechnology website, and that you can utilize that guideline.
Okay.
However, I do want to point out that the CLSI document is referenced both for ISO, and it's really not that expensive, and I would recommend. It's the most up-to-date document. And I think once the ISO document comes out, I think you'll be pleased with that. Kurt and myself were the chairs for that document, and so it's a very good document, very good.
Okay.
Okay, but then we will see you later on for the next session.
Yes.
And we go further in a break at this moment so that we can just drink something. Okay, so bye, and I'll see you later.
Okay.
Okay, bye.
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 Oh,